Good morning, good afternoon, and good evening, everyone. It is a great pleasure to welcome you all to today's WFSA's webinar, Distilling the New WHO Guidance on Implementing Patient Blood Management to Improve Global Blood Health Status. My name is Vicente Fonseca, one of the moderators of this webinar. Let me just share my screen. There you go. I am an anesthesiologist at SANE in Brazil. I'm currently the Vice President of the Brazilian Society of Anaesthesiology, Professor of Anesthesiology at UNISINOS University, and a member of the WFSA Council. To co-moderate this webinar, I present Professor Christina Lundgren-Steele, Head of the Clinical Governance of the Wits Donald Gordon Medical Center, and Honorary Professor at Steve Biko Center for Bioethics at Wits University in South Africa. PBM is more than a strategy, it's a cultural and clinical shift in how we care for patients who may require transfusion. Instead of focusing only on blood products itself, PBM places the patient at the center, aiming to optimize their own physiology, reduce unnecessary transfusions, and improve patient safety and outcome. With that, the WHO's new guidance on PBM marks an important step in moving from principles to global implementation. The guidance provides a structured roadmap for health systems around the world, highlighting how PBM can strengthen patient care, reduce risks, and at the same time improve the healthcare sustainability. Today, we are fortunate to have three distinguished speakers who will help us translate the guidance into practice, sharing insights from their expertise and experience. I'd like to extend a warm welcome and sincere thanks to each of them for joining us and for contributing to this important discussion. And finally, I would also like to thank you all, our audience, for being here. Your engagement and commitment are essential to making PBM a reality in daily clinical practice and across health systems worldwide. With that, let's start our program. Some housekeeping before we start. You will have Q&As that can be submitted via the Zoom Q&A function. This webinar uses Zoom's AI translation feature for live subtitles. Our certificates of participation will be issued within 15 business days, and to qualify, participants must attend for at least 60 minutes. About webinar recording, the recordings will be published on YouTube soon. A link will be sent by your email. I'd like to remind everyone that our registration for the World Congress of Anesthesiology is now open, and the early bird deadline is by January 21st, 2026. I would like to also remind you of the Santa Cruz Declaration on PBM. And if your national society has not yet signed, please go to this QR code and join over the more than 100 organizations that has already signed this declaration. And I would like to present our first speaker, Professor Dr. Axel Hoffman. Dr. Hoffman is a doctor of medical science with a master's degree in economics. He's an adjunct professor of the discipline of surgery and clinical training and evaluation center in Medical School University of Western Australia. He consults governmental, public, and private institutions on the implementation of PBM in Australia, Austria, Brazil, China, India, Italy, Mexico, Russia, South Africa, South Korea, and Switzerland. He was the lead contractor of the world's first statewide PBM implementation project and PBM implementation projects of several public hospitals and hospital systems in Europe. He currently serves as chair of the World Health Organization's External Steering Committee for the development of a policy brief titled The Urgent Need to Implement Patient Blood Management and the development of a guidance for worldwide implementation of PBM. Dr. Hoffman, it is an honor to have you here. Thank you very much.
Thank you, Vicente, for this very kind introduction. Hello to everyone in the audience. I'm just loading my presentation. And here we go. Overview of this WHO guidance on implementing PBM is my title, and I'm really trying to whet your appetite. And let me just start with my disclaimer. I work for government and public institutions, professional societies, and NGOs, blood services, and for some projects with industry funds or grants. This is the title page of the new guidance document. And it says, who are the intended audiences for this document? And if you read through it, you will see it is senior staff of health departments, health ministers, chief medical officers, health commissioners, directors of health, members of health councils, heads of regulatory bodies. And you might say, well, where is my role? I'm an anesthesiologist. Well, this is one part. The other part is, of course, the executives of hospitals. And then we have clinicians, starting from hematologists through oncologists, through cardiac surgeons, to nephrologists, etc. You have people who implement and bring the two worlds together, public and patient level health. But today we want to concentrate on what is your role or potential role in the implementation, how you can use this guidance document. And I think it is in many institutions, the Department of Anesthesiology, who is almost a gatekeeper for this new paradigm, let it in or don't let it in. I assume that many of you are familiar with the policy brief from 2021, the urgent need to implement PBM, and it has very strong, compelling arguments. And I would say it is a no-brainer. It needs to be implemented. So you can tick box the why. The big question is how to implement it, because many who try it or want to embark on that journey are somehow struggling. I want to show you three important lines that are quoted more or less from the document directly. We're saying the most neglected organ, and I'm highlighting the word organ, not just tissue. The most neglected organ is the patient's own blood. And we know this because we have about 3 billion people on planet Earth that are either anemic or micronutrient deficient, or that are constantly or acutely bleeding due to blood loss, surgical blood loss, or due to coagulopathy with bleeding. And because this organ is so neglected, the only medical model to sustainably rectify this is patient blood management. And the therapeutic goal is blood health. We know about brain health, kidney health, gut health, and we also need to bring blood as an organ into the focus and make sure it is kept healthy. At the end of my brief presentation, I want you to remember this acronym here, 3P8, 3E, and you will understand in a moment why. Let's start with the P's. You see here, improve population health status is what public health experts want to do and are paid for doing. And what they have to do is promote health, protect health, and prevent disease. And when we translate this into blood health, then we know from the literature of the last 1 or 2 decades that PBM actually can do the 3 Ps, the promotion, protection, and prevention part. And so one big driver from a public health view is basically the 3 Ps to make PBM a standard of care. Now we go to the patient level, and we can say that PBM is good clinical practice. It's not a single bullet, it's not a single intervention, it's a bundle of care and includes diagnosis, therapy, and follow-up. And in fact, it also includes prevention. And the evidence is overwhelming. We have sufficient evidence that shows that clinicians should adopt it and health authorities should mandate it. So there's evidence for the stakeholders, the many stakeholders I've shown you in the beginning, that are alerted to do something or to act. We also have a very strong economic argument in favor of patient blood management with saving potentials of macroeconomic dimensions. And when we have, and when we look at the various studies and the evidence on the economic side, we can also see that stakeholders are enabled to act, because patient blood management is not an expense, it's an investment and it has an incredibly high return of investment. So if we have both the evidence and economics in the right place, then it goes without saying that there's an ethical obligation to make this a standard. So, and this is the 3 E's. And they run this machine here that I'm trying to show you as a symbol for the government. So again, led by the 3 P's: promotion, protection, prevention of health. And down here, the different, the individual healthcare organizations. And we've got to bring these 2 worlds together when we are talking about this huge paradigm shift. And this is what we developed the 8 model for. It starts up here on the top left, preparing the national or jurisdictional healthcare system for PBM is a requirement that is very much wanted. And part A of the document describes phase A, exactly this preparation phase. And it's these stakeholders that we showed you at the beginning on the left side of that first slide. Once the preparation is done, you go into the second phase down here, the bottom of the 8, conducting PBM pilot projects, or at least one single project that could later be a reference project, reference center for the country. And this is section B, or phase B of this document, very rich in information, and it addresses the do's and don'ts and do's for the various clinical groups in a hospital system. And once this is completed and we have successful pilots to present, then we go into the final phase, which is rolling out on national jurisdictional scale, so upscaling what has been learned. And this is again under the auspices of the basically of the healthcare authorities. So we call this whole model the 8 model to implement PBM. And again, because it's helpful for you, even as an anesthetist, that you see what we want the governments to do to make your work in that respect easier. The first 2 steps are really addressing the Ministry of Department of Health. There is a need for a national adoption of the policy, followed by establishing a governance for the implementation. There must be a body within the country, within the nation jurisdiction that is responsible to make this happen. And then with that governance, they hand over to what is here on the left side, a national jurisdictional implementation task force. And the first thing they should try to do, because there's little latitude for public health authorities to influence clinical work, except for anchoring PBM within the WHO-aligned quality and safety framework, because it is a quality and safety issue. Once this is done, the next thing is the education, not only for professionals, but also for the undergraduates, should be mandated, because you cannot anchor something in the framework, quality and safety framework, that is not taught properly. Then we also need to empower the public on blood health and the individual's responsibility to look after his or her own blood count and blood values. We also need to secure the access to essential PBM medicines and devices, and finally allocating resources for PBM. And I want to underline once more, it's a reallocation of existing resources to get the bigger bang for the dollar. And finally, you select within the nation the right PBM pilots, and then we switch over into the patient level with these next 6 steps. Step number 9, 10, and 11 is pretty much on the shoulders of healthcare organization-based PBM champions. What do we understand as a champion? Well, clinical champions are individuals who are dedicated to supporting, advocating for, and spearheading an implementation initiative, who overcome resistance that may occur at the organizational level. And again, it's often the anesthetist who does it, and they have often shown that they are able to motivate others to join the flock. So the champions would initiate and drive this concept. They would start talking to their peers. They would prepare the argumentation. They would do some preliminary, let's say, studies of empirical data. They would prepare the implementation, and only when they have done this kind of homework in step number 10, then they would approach their senior management of their organization and ask for an authorization of a pilot project. And this is a very, very big hurdle sometimes, and it sometimes needs 2 or 3 attempts to overcome that hurdle. But once this is done, then it goes on with a healthcare organization implementation task force. As we had it on a jurisdictional level, we also need it on an institutional level. And usually it is the champions that then populate the task force over there. And the first thing is they create a healthcare organization-specific PBM structure. They need to have, for instance, the right structure to run in a periop clinic, to do many different things that are required when you have PBM continuum of care. Here is, by the way, an organizational structure during the implementation period. On the left-hand side, on the right-hand, it's after the implementation. But you see what you need to run, what you need to organize are 4 major work streams. It's PBM data, it's PBM education, it's communication on PBM and blood health, and it's the actual clinical PBM processes for different patient populations. Once you have that, you really start with the actual processes that are needed to put in place. And now this is where the guidance is very rich in information. It has powerful tables, figures, and boxes with very important complementary information. It has in Annex 4 how to measure PBM with 11 structure process matrix, 16 outcomes matrix, and also the p-PBM matrix that have been developed by a group of anesthetists in Spain. And they are very well structured. We don't have the time, so go into the document that you should download at the end. Annex number 5 has links to PBM and PBM-related clinical guidelines, consensus statements, etc. And then Annexes 6 to 11 is what we call the PBM toolkits. They are looking into toolkits for patients in low-income countries, lower middle income, upper middle income countries, and high-income countries. So we looked at the socioeconomic determinants of the different countries. But then we have 3 very specific ones, one on neonatology and pediatrics, that was with the help of Susan Gooby and David Faraon from Harvard, one on obstetrics and one on trauma. And again, they are very rich in information, and they are structured around the A, B, and C problem. A like anemia, B like blood loss, and C like coagulopathy with bleeding. And finally, we show in the document how you can use it to design and implement continuum of care from the most resource constrained to fully equipped healthcare systems. This, for instance, is a pathway, a continuum for major elective surgery in urban high-income regions. But we also have some information how you can run this in a low-income country, just with community health workers, because there is a lack of nurses and a lack of physicians. And once you have passed this pilot project successfully, then the government should decide what are the centers that should be selected as reference centers. They should decide what are the key performance indicators that must be mandated to keep an eye on the development of the implementation process. They should start with certification for clinicians, followed by accreditation of institutions. We have 16 PBM standards suggested in the document that can be used for accreditation. And finally, PBM research and development. So the summary is, if you want to run this engine, this tool, this aid model, then you have to play it with the 3 Ps to convince the public health authorities, and the 3 Es to convince your peers in your organization. And this is my last slide with the words of Yukiko Nakatani, Assistant Director General of the World Health Organization, saying that hundreds of millions of individuals can benefit from this detailed yet practical approach to improve their blood health status, and it allows the reallocation of limited funds to where they are most needed. So take a screenshot from that here. This is the the QR code for this document. Download it as often as you can. Please don't spread the PDF, spread the link, because we want to see at WHO how many downloads we get to again have a little bit of a feel of the uptake. So thank you for your attention.
So our next speaker is going to be Professor Daniela Filipescu. She is currently the president of WFSA and also a co-chair of the WFSA Perioperative Patient Blood Management Working Group. Professor Filipescu is a cardiac anesthesiologist, professor of anesthesia and intensive care medicine at the Carol Davila University of Medicine and Pharmacy, and chief of the cardiac anesthesia and intensive care department at the Emergency Institute of Cardiovascular Diseases in Bucharest, Romania. She also holds a master's degree in health management. Dr. Filipescu's main research interest is in blood health. She co-authored a couple of PBM European, international, and national guidelines. So thank you very much, Dr. Filipescu.
Hello, everyone. And thank you for being here with us. Thank you, Vicente, for the kind introduction. And thank you. I don't know if you see my slides.
You need to start from
yes.
the first slide.
The first slide.
Okay.
Yes.
No, it's not the first. Thank you, Axel, for the wonderful presentation, and congratulations for publishing under your leadership the WHO guidelines for patient blood management implementation, because there are many challenges still in implementing patient blood management. So this guidance was so much awaited and needed. And,
thank you, Daniela.
You're welcome. And why is this? Because there is a big gap between evidence, what we should do, and the practice, what is happening in practice. And to achieve the goals of implementing patient blood management, we have to identify the barriers and facilitators and to address them accordingly. And to support this statement, I will present this recent and impressive study, because it included 1.2 million patients coming from German patient blood management network. They included 14 German hospitals, and over a period of 10 years, it was a before and after introduction of PBM programs. And they showed the superiority of patient blood management regarding red blood cell transfusion, and also the safety of these programs. They look to composite endpoint, including in-hospital mortality and selected post-operative complications. And as you can see, transfusion was indeed reduced, but only 14%, which is lower than we expected and we saw in other studies. And in fact, the difference rate of reduction was 10%. It was different in depending on the type of surgery. The results in cardiac surgery, in urology, gynecology were more impressive. But as also the authors are mentioning in their comments, there were differences between the centers. In fact, 3 of the 14 centers did not achieve reduced blood transfusion. And centers, this was higher, the reduction of transfusion in centers with a baseline high transfusion rate. Also, there were better results in university hospitals. And if 80 to 100% of the suggested intervention have been implemented. So obviously, there are barriers and facilitators in implementing patient blood management, and these were described in the literature. Most important were related to education gap, lack of awareness, lack of funding, resistance to change. But I would add also the contradictory literature. This is in my opinion, an important barrier in or slowing down the implementation of patient blood management and low compliance. And also, when we look to facilitators, which are very important to overcome the barriers, we probably have to change a little bit our discourse and not only to look to outcomes, cost savings, patient safety, but also to show to not only to our colleagues, patients, but also to authorities that this is means to reallocate the resources, to decrease the waste, and to increase the equity in health care. In this study coming from Spain, from orthopedic surgery, it was shown how important is the adherence to patient blood management clinical pathway to decrease the postoperative complications. The higher the adherence to this patient blood management clinical pathway, the lower the complications, including infection, major adverse cardiac events, also transfusion rate. But unfortunately, you see the mean adherence rate was 60%, so there is room for improvement. And the same message we got from the French analysis of the surgical departments implementing patient blood management. We saw that despite the positive results regarding treatment of anemia, transfusion rates, length of stay in the hospital, still more than half of patients with anemia and iron deficiency are not treated preoperatively. But there are other barriers which are important in my opinion, such as conflictual, contradictory, controversial messages in the literature, and even unfair ones, because if you look to this meta-analysis, which is a great one, including almost 400 studies, they show that there is efficacy related to patient blood management intervention, blood transfusion, blood loss, reoperation for bleeding, length of stay in hospital, all are reduced, and the blood transfusion is reduced even higher when more interventions are used together. However, when you look to the title, you may feel disappointed because it's written that patient blood management intervention do not lead to important clinical benefits or cost effectiveness, which is, in my opinion, controversial and in a way misleading. This meta-analysis also mentioned that there is no cost effectiveness, but afterwards some studies in Turkey, in Germany, in France showed that there is cost effectiveness for implementation of patient blood management. And in this budget impact model based on almost 1 million patients in France, they showed impressive results, sparing almost 100,000 units of red blood cells, and cost savings of almost 1 billion euro for the national insurance in France. But as I mentioned, probably we should also look to other messages we have to convey to authorities to convince to take the lead in implementation of patient blood management as suggested, as recommended by the WHO guidance. We have to make very clear that patient blood management may decrease the waste in healthcare, because healthcare, it's in the state, it was estimated that the waste counts billions of dollars, and there are 6 main categories, and through patient blood management we can overcome the overtreatment and provision of low care, only if we think that by transfusing, not always we can increase the oxygen delivery, we can decrease the over transfusion. We can also improve the care of our patients by taking the opportunity, this missed opportunity of treating anemia in the preoperative period, because it was shown in a large European study that 80% of those transfused intraoperatively came anemic to the operation. And also we can coordinate better the care, as it was shown in the guidance. We can construct this continuum of care for our patients. And also it's important to highlight that patient blood management may increase equity in health, because we know that we have to increase the number of surgery, access to surgery all over the world, but the context is that population is anemic in 33% of cases, and the blood donation is insufficient for increasing the access to surgery. So in this context, to increase the access to surgery and universal health coverage, we should implement patient blood management interventions. Our experience in Romania proved that the uptake is slow, but now after seeing the recommendation in the WHO guidance, we understood that we didn't follow the best pathway, and will change in the next years. For sure we'll achieve more results. We started 15 years ago with establishing an anemia working group. Then we established an initiative, patient blood management for the perioperative period, and we published some recommendations in our Romanian Journal of Anaesthesiology, and hopefully they were endorsed by the Minister of Health and published as national guidelines in the official gazette. And we continued being involved in many educational events. In the last 10 years, every National Congress in Anesthesiology has a session on patient blood management. We took also the opportunity of having the national guidelines for safety in anesthesiology, mentioning that preoperative evaluation is mandatory at least 1 week before surgery, and we ensure some reimbursement for patient blood management interventions, especially the preoperative anemia treatment, and also some drugs and devices for critically ill patients, specifically for patients with severe hemorrhage. But if you look to the guidance, now we understood that we didn't start where it should. So we didn't start from the top. In fact, we start at step 9 with champions in different hospitals. And although I have to acknowledge the help we had from the authorities in publishing the guidelines and also allocating some resources. And we use as a model the quarter model for change, starting with establishing the need, the urgency of patient blood management, and having a strong coalition. But where we arrived, I am not sure that we reached to anchor the patient blood management in the national culture. However, we are doing well in the anesthesiology community in Romania, because we have done a survey in 2023, 5 years after the guidelines were published, and we were happy to see that 97% of our colleagues consider that patient blood management is useful for the outcome of surgical patients, and 74 declared that they apply daily patient blood management. 47% they state that they have institutional implementation group and mostly run by an anesthesiologist. But when it comes to anemia treatment before major surgery, you see that only 28% is declared they are doing this. Usually, despite the fact that more 54 have some policies in-house for this, and also the availability of tests and the drugs for treating anemia, it's not bad, as you see from these slides, and all this implementation are higher, rates are higher in hospitals having a group of PBM. But we still have problems with the timing of pre-anesthetic consultation, despite all the regulations, and the majority, you see, usually they see the patients one day before surgery or a couple of days before surgery. That's why the most important barrier mentioned by our colleagues was the short preoperative timing before the intervention. And it's important to mention about the cultural context, that they mentioned the difficult cooperation with the surgeon, meaning that surgeons do not like to postpone surgery, schedule surgery, if the patient is anemic for treatment of anemia. That's why the colleagues mentioned that it's needed to have a government decision for outpatient or pre-anesthesia clinic, and also it's needed the digitalization of patient records and having more audits and data. And we started to have to collect data in our institution, which is an institution for cardiovascular diseases, and we published the results in different journals, and it helped us to shape the progress of patient blood management in our institution, and suggestion for our colleagues, because we realized from this study that we still have to work intraoperatively. You see in the right, independent of the level of hemoglobin after surgery, all the patients are discharged anemic. And also a very important thing which we found was as a predictor of transfusion in the perioperative period was, besides the usual ones, was the use of fresh frozen plasma, which in other words means that we use too much fresh frozen plasma in our cardiac surgery patients. In this other study, we after and before and after implementation, we showed that we succeeded to decrease the use of fresh frozen plasma, and this is a important benefit. And also we confirmed the perioperative factors for risk factors for transfusion, which stimulated us to look closer to the preoperative measures. And we succeeded only last year in September to launch the pre-anesthesia clinic in our institution. We wrote and published some leaflets with information for patients, including data about anemia and transfusion, and also use regularly the hemostasis questionnaire. Why it took us so long? Probably in my explanation is that first of all, the lack of human resources was one important reason. This was not captured by our survey, but another survey performed in Romania showed that yes, this is a number one problem for implementation of patient blood management. And this, I think, is a challenge all over the world, because if you look to the workforce map, there are there is still a huge need of more anesthesiologists, especially in Africa. But you see also for my country, in the region, we have the lowest ratio of anesthesiologists for 100,000 population due to migration. So the take-home message is that we have these specific barriers and facilitators that need to be identified, and strategies to encourage the implementation of patient blood management need to be anchored in the context of the organizational culture. Thank you for your attention, and I'm happy to answer your questions.
Thank you very much, Daniela. It gives me great pleasure to introduce our African speaker, my fellow African, Dr. Naima Yusuf, who has huge experience in conducting training for safe obstetric courses. She's a member of the Safety and Quality of Practice Committee for the WFSA, and she's the country representative of the SAFE programs in Tanzania. And I see there's an obstetric question, which I'll ask Naima to answer after all the presentations. Naima has also she was also a former director of the referral hospital in Tanga for the past 4 years, and supports all anesthesia activities in the region, which has a huge number of hospitals. So welcome, Naima. We look forward to your talk. Thank you.
Thank you so much, Chris, for the introduction. I will be sharing my slide. And I hope we can all see. Yes?
Yeah.
Okay. So thank you, Daniela and Professor Axel, for wonderful yet concise presentation. We will now look into implementation of PBM in Sub-Saharan Africa. And I'm going to talk to you about the urgency of implementation of PBM in South Africa with its key strategies, role of anesthesiologists in PBM implementation, and one success story which astonished me through its achievement. There are tremendous achievements seen in implementation of PBM in high-income country, which was just stated by Daniela. One of the study which I looked into was implementation of PBM in Australia from 2008 to 2014, and it revealed a good patient outcome in terms of decrease of mortality, infection, and length of stay. There was also increase in single transfusion instead of multiple transfusion, which exceeded before PBM implementation. There was also decrease in the need of red blood cell transfusion to almost 43%. So now talking about PBM implementation in Sub-Saharan Africa, is it really important? And the answer would be yes, because PBM makes a lot of sense for Sub-Saharan Africa as it reduces our reliance on limited blood bank supplies. This was seen by National Bank transfusion unit in Tanzania, whereby the needed units are 10 units per 1,000 patients, whereas from up to 2016, they were only able to give around 3.6, like less than 4 units were available. And PBM is safer and more cost-effective, as seen in one of the studies from Brazil, which said around estimated cost per unit was $50. And it's also more sustainable. It directly benefits our valuable groups, pregnant women at risk of postpartum hemorrhage. As seen in 2015, more than 2/3 of 3,000 maternal deaths were due to hemorrhage. Even other beneficial groups are children with malaria-related anemia and trauma. One other study, which was done again by Dr. Bombo in Tanzania, they said that there was overuse of inappropriate blood transfusion. Like out of 460 blood units, only 32.8% were transfused appropriately. So as we now know that this is really a problem and PBM is a solution, so what can we do? So we need to change the management. And I'll take you through the Lewis model of change. First, in the unfreeze stage, we need to identify the current gaps in blood use, raise awareness through education and research, and gain management support. Next, in the change stage, we implement the new practice through training staff and encouraging a team approach to PBM. Finally, in the refreeze stage, we take blood patient blood management, the standard of care, by embedding it into the policies and sustaining change through ongoing monitoring and reinforcement. In short, this model helps us move from recognizing the problem to making PBM a routine, lasting practice. After talking that, what are the key strategies? And I'm thankful to Professor Axel who took us through some of the key strategies, and I've picked some of them about to see whether how it's going to be implemented in sub-Saharan. So these toolkits are embedded in WHO PBM guideline, and they're groups of materials, rules, and action that can be taken. They make to work in varied resource constraints. So it's not only available in high income, but also low income countries. And the goals are to deal with specific health problems like anemia and too much transfusion, as we had seen in our previous slides, but also making sure the patient care are safer and better, and helping healthcare workers learn more and do better at what they are doing. The second strategy is the continuum, of course. So WHO follows through PBM a continuum care of model, meaning interventions should be applied throughout the patient's journey, from pre-hospital care to hospital admissions and surgeries to discharge and community follow-up. In Tanzania, our PBM plan is towards dealing with the high rate of anemia in our country, improving blood health before and after surgery, and some of the interventions have already been taken place through training appropriate use of blood transfusion, but also making sure that there is a follow-up care available at community level. The education, I must say, is a center to making blood PBM sustainable. This means embedding PBM in the core curriculum of medical and nursing students earlier and mandating continuum education to practical clinicians. In low-income countries where blood supply is constrained, empowering professionals and patients with PBM knowledge is a cost-effective way to improve outcome and promote health, blood health. Promoting blood health goes beyond the hospital. Before, there was a blood-centered education, but WHO said, whereas it declared in 2021, now we want it to be patient-centered. So it highlights the need of community and patient empowerment by raising awareness about anemia, transfusion alternative, and safe practice. PBM becomes not only a clinical program, but a public health movement. This empowers individuals to actively engage in their own health. After that, we need to now conduct a piloting project in practical way to introduce PBM, starting with a very small thing, allowing us to test, small pilot, which will allow us to test the feasibility, identify the barriers, adapt intervention before scaling up to the national level. They also generate, sorry, actually I'd forgotten to start my video, I'm sorry for that. They also generate valuable evidence on patients' outcome and cost saving, which helps secure long-term policy. And as Professor Axel said, refunding or reallocation of the funds to support other activities. Okay, some technical problem, yeah. So finally, let's look into Annex 3 and 4, which is well stated in the WHO BPM guideline. And this matrix includes the structures and processes indicators, such as establishing PBM stewardship and hospital accreditation, as well as the outcome measures like anemia, prevalence, and mean hemoglobin levels. WHO and IHME already track some of this globally, making it easier for the country to benchmark the progress. Coming to the role of anesthesiologist, as stated very well by Professor Axel and Daniela, solidified it, we are the champions, and we should be there for early screening of the surgical patients, treating anemia before the surgery, and also counseling patients about the risk of blood transfusion and giving them options for alternative instead of blood transfusion. In theater, we are responsible for minimizing the blood loss by giving tranexamic acid, maintaining normothermia, avoiding overdilution, and even employing low-cost salvage technique, which can preserve the patient's own blood. Post-operatively, to use restrictive threshold and optimizing oxygen delivery first can save blood units for those who are in real need. Here I share a case which I just dealt with it today. We had a PPH patient, an APH patient who we took to the theater, and the surgeon wrote 4 units of blood. But through giving tranexamic acid, the need went all the way down to 2 units, and the patient is doing quite well, and she is in ICU with good blood pressures. Secondly, the last, I would also like to now share with you the success story. This is like in 2019 in Brazil. Brazil has like almost the same constraint and same problem as us in the sub-Saharan Africa. And it is considered to be low middle income country. And they implemented comprehensive patient blood management in Ceará. And their essential facilitators were government support and multidisciplinary collaboration. They expanded through this program service, which included the introduction of 5 outpatient and perioperative clinics. They enhanced in gynecological bleeding care and also implementation of trauma protocol. Not only that, but they were also able to have standardized intervention and composing techniques such as cell salvage, normovolemic hemodilution, erythropoietin administration, intravenous iron within vitamin B12 supplement, and the use of antifibrinolytics. Technology and policy have incorporated viscoelastic coagulation testing and established the guideline for single unit transfusion with restricted threshold. The total cost estimated or associated with PBM amounted to $0.9 million, resulting into direct saving of around $4.7 million and potential activity-based saving up to $23.8 million. That's amazing. So that just tells you that in conclusion, PBM in Brazil is variable even in resource-constrained environment, facilitating improved distribution of healthcare resources. To summarize my presentation, PBM in sub-Saharan country is doable and much benefits, especially where the demand of blood transfusion is high. Therefore, by using WHO recommended strategies, PBM is going to solve a lot of challenges which we are facing due to blood transfusion. I would like to say through PBM, we are empowering the change, which results into empowering our patients. Thank you very much for your attention.
Thank you very much, Naima.
So thank you very much for our 3 presenters, Dr. Hoffman, Dr. Filipescu, and Dr. Yusuf. I would like to remind all of our audience that you can submit your questions in the Q&A box in the lower part of the screen. And we have a few questions already. and I'd like to start with the first one. The first one is, thank you very much, all WFSA team and other facilitators and contributors. My question is, how can we implement PBM obstetrics in the rural areas, and what is the acceptable value of hemoglobin in order to continue surgery? So as Daniela previously mentioned, probably that goes to Naima. What do you say, Naima?
Yeah, that's true. So it is there are different studies which are done. One I think was done again in Brazil, whereby the expected level before it was almost to 8 gram per deciliter, but through interventions with PBM, it went all the way down to 7, 6, 7, and this is achievable because of giving those supplements. You see, tranexamic acid is very important, and if it's available, if you're using it correctly, intra-op, pre-op, it brings the achievement. Many people think the low blood pressure which happens in acute bleeding is only because of the blood, which is not really true. Sometimes vasopressors also have role in doing, and as I told you, I have just had an example of a patient who were instructed to be given 4 units, but we only managed to give 2 units with the help of tranexamic and vasopressors, and the blood pressure is normal, and we are still continuing to monitor the patient, and this is quite doable. So it really depends from the setting you're coming. You need to do a lot of research, come up with your own policy, look at what level. I'm sure you don't have access to blood transfusion all the time. So look at the level or of HB, which is doable, and continue giving the care. Yes.
Thank you, Naima. We've got a question here for either Axel or Daniela. Greetings. What is the minimum acceptable hemoglobin a pediatric patient posted for cataract surgery with comorbidities and without comorbidities? Daniela.
Let's start,
Oh,
Daniela.
Axel.
You want to start? Daniela, you go first. Ladies first.
No. Oh, yes, thank you. I don't have the answer. This is the honest
Well,
and okay.
no,
You know, because first of all, I am not a pediatric anesthesiologist, but it's difficult, and I suggest to look to the guidelines for pediatric patients. And we had a wonderful webinar in February regarding pediatric topics with Susan Gobi. But I think that I do not trust in this idea of minimal with the minimal level of hemoglobin we can accept, because this depends on many things: hemodynamics, ventilation, anesthesia. So I don't think in the literature you can find for adults different values for the lowest hemoglobin, even 1.9, I think, in one study. So I would not go for the lowest acceptable. I will try to prevent these low values by all the means we can have in the perioperative period.
I can only echo what Daniela said. The elegance of patient blood management is not to sit and wait, but being preemptive. And if we look at studies of anemic patients, regardless of what population, I'm always asking a question: why have they been enrolled, and what has been done to prevent and treat their anemia other than looking at transfusion? And you're always surprised how often the audience is kind of embarrassed because, yeah, this is just not the culture. But we've got to change the culture. The biggest enemy, we are not making transfusion the culprit. We are making the lack of etiology-specific management of A, like anemia, B, like blood loss, and C, like coagulopathy with bleeding. If we have these upstream problems in the focus, then we don't get to the downstream problem of transfusion. And I know that in Africa, even if we would say, well, there was this Lacroix study in New England Journal of Medicine in pediatric ICUs, where they tested 7 versus 9 grams following the trick trial from 1999. and it showed that restrictive is much better. But if we look at Africa, we know that so often blood is not available. And there was a study by Maitland, also published in the England Journal of Medicine, where they said, well, we have for severely anemic African children a threshold of 4 grams, and we feel that looking at this very dear population, our next generation, our kids, we've got to raise this possibly to a 6 gram threshold. And then to their surprise, they saw in that study that there was absolutely no difference in outcomes between 4 and 6 grams. However, the utilization of blood was twice as high in the 6 grams group. So I think the discussion should move away from thresholds and should move into a timely and effective management of anemia and its etiology.
And if I may add, we need more and other means of monitoring, because with the current monitoring, it's difficult to say if enough hemoglobin it's arriving to the tissues and especially to the mitochondria. So it's difficult to say how much it's in the mitochondria where the oxygen is needed. So we are waiting for more means of tissue oxygenation monitoring.
Absolutely, and we see from a number of studies, and I worked many years with my friends in San Diego at the Department of Bioengineering with Marcos Intalieta and colleagues, and we have shown that the hemoglobin, the stored blood, has totally different properties compared to your own circulating red cells, and hemoglobin doesn't equal hemoglobin. In fact, we see with stored blood, of course, an increase of hemoglobin when it's given, but we don't see that much increase of DO2, and we don't see almost no increase of BO2, and also no change in lactation, which means that the stored blood in at least unless we don't speak of severe anemia, the oxygen doesn't arrive at the mitochondria and doesn't produce ATP. That's exactly what you said, Daniela. Great, thank you.
So thank you, Dr. Hoffman, and also Daniela. So I have another question from Anna, and she says, I'm in extreme low resources hospital, for example, humanitarian missions. How to implement a PBM program? That's one stuff.
I think Professor Axel can answer that.
Okay. Number one, I'm just having here this study, randomized trial of early detection of treatment of postpartum hemorrhage. It's just, again, mainly on Africa, 2 times 55,000 or 50,000 patients. And you might have heard of the study by Gallos and colleagues, the emotive study, early detection and trigger criteria, message of uterus, oxytocin, tranexamic acid, IV fluids, and examination escalation. Or the other paper in Niger, where they just had 3 measures with ultrasonics, condom tamponade, and inflatable anti-shock garment. And with these measures, they reduced in Niger, one of the 10 poorest countries in the world, they cut the mortality rate from postpartum hemorrhage into half. In fact, they ended with a lower mortality rate than the United States, which was embarrassing. But what I would suggest to the person who raised the question, please go to the annex of the guidance document and pull up the toolbox on gynecology and on obstetrics, and also look at there's one example of I think 17-step continuum of care in a rural community health worker, lay health worker driven or organized obstetric center, and get some very practical ideas from it. This was not developed by people living in the ivory tower and being purely academic. This was done with the support of Freddy Kabambi He is an anesthetist in one of the poorest countries of South Africa, poorest parts of South Africa. And in his first year of implementing PBM in an extremely resource-constrained environment, he was able to hire 5 new junior doctors because of the reallocation of funds and better used resources. So really familiarize yourself with the toolbox and with the document and with his annexes and his methodology, as Naima has obviously done. And by the way, Naima, a brilliant presentation. Thank you so much.
Thank you. Thank
So
you.
it's all there. You know, we just need to start to use the material.
Thank you, Axel. The annexures are incredibly important. Daniela, this is for you. The alternative for transfusion in neurosurgery, PBM-wise, considering PBM.
So in all kind of surgeries, we can look to all the measures we can have regarding alternatives. So antifibrinolytics, also the temperature and all the measures we have to keep during operation to have the best milieu for coagulopathy. So, but for neurosurgery, I think that it's very important, as for cardiac surgery, to look to the preoperative evaluation of hemostasis. We have to have protocols for antiplatelets, anticoagulation drugs, how to deal with them. So patient blood management, and I would like to highlight this, is not only about transfusion and about anemia. It's also about all the measures we have to implement to optimize patients. So we have to start with the preoperative, and also in the intraoperative and postoperative, we have to apply what we know and we are doing usually currently as anesthesiologists, but we have to have protocols in our environment. We have to look to look to our to audit and to know how are our surgeons and we are performing, what is the need for blood, what is the risk, and then starting from here to build the protocols. And we should always stay at the table with our colleagues from other specialties, especially neurosurgeons in this case. So also for hemoglobin levels, there are, patient blood management is about treating anemia and being also very judicious with blood transfused. There are new studies looking to hemoglobin levels. We should transfuse. Please read carefully, and not only these studies, but also the comments on the studies.
Thank you, Daniela. If I might add, since I work with neurosurgery in a daily basis, and especially in a center that performs skull-based surgery, so very highly bleeding neurosurgeries, sometimes 3, 4, 5 liters of bleeding in surgery. And I would also say that monitoring intraoperatively is very important. And in one of the centers that I work, we do not have access to viscoelastic tests, but we do it with standard laboratory tests. And even with standard laboratory tests and also monitoring fibrinogen level and other standard coagulation tests, and also venous saturation, and using small volumes of colloids together with crystalloids, we can manage to save a lot of transfusions. Sometimes we have up to 2-3 liters of bleeding in the patients, and we don't transfuse them. So that's very good, very important.
Vicente, there's a question here. Expensive tests like Rotem have been associated with the optimal implementation of PBM. Is it cost-effective option for low and middle income countries? Can you follow on and answer that? And then I think we might need to start wrapping up.
Perfect. So this, if the presenters allow me to answer this one, in countries like Brazil, I can speak for my own country. I'm from Brazil. Viscoelastic tests are incredibly expensive, and we have that in less than 1% of the hospitals in Brazil. But that is not a reason not to do PBM. So we can do PBM very, very effectively without viscoelastic tests as well. So treating anemia does not require viscoelastic tests. We could, and we know that the best preoperative monitor for coagulation is history. So it's history taking, it's physical examination. This is much better than any test. Intraoperatively, from my experience, since only of the 10 hospitals that I work here in Brazil, only 2 of them have ROTEM. The other 8 don't. From my experience, standard coagulation tests taken intraoperatively in a timely manner with a very good communication with the laboratory, so that laboratory can perform those tests more rapidly. And if you use those standard coagulation tests in a protocol manner, they can be a very good option for the situations where you don't have the viscoelastic tests. So for fibrinogen measurement, prothrombin time, activated TTPA, as well as platelet counts, those 4 tests can give you a very good, although not as complete as viscoelastic tests, it can give you a very interesting overview of coagulation, and they can save transfusion. So for instance, if you have a fibrinogen count that is below the threshold, you can use, for example, fibrinogen concentrate and avoid plasma with other results. So that is very interesting, and that has helped me and many other colleagues here in Brazil. But the important thing is to use them in a protocol manner, to have a good communication with the laboratory, and also remember to test fibrinogen, because oftentimes I see people forgetting the most important coagulation factor and the first one to dilute in bleeding situations. So I think that's it.
Thank you. Prof. Hoffman, Axel.
Yeah, great comment, Vicente. And it just reminds me that we have to repeat as PBM champions, PBM is never a single modality. PBM does not, as he rightfully said, not on a single technology or modality. The power of PBM lies in this bundle of care, with a bundle of diagnostic and therapeutic measures. And we have many good studies on single modalities and their impact, but then we have studies on combined modalities, and then we have studies on the full-blown PBM bundle. And we see the more you bundle it, the better the outcome is. And this is that culture change. And if we don't have a specific technology at hand at the moment, there are always ways around it. But keep in mind, management of A, B, and C is the problem, is the challenge. Anemia, blood loss, coagulopathy, bleeding.
I'll give our WFSA president the last word before I wrap up.
Thank you.
I'm sorry.
Thank you. Just to add to what
No
was
problem.
said about viscoelastic tests, they are in many parts aspirational. But if you look to the guidelines recommend either standard coagulation or a viscoelastic test. So you have to implement patient blood management, not be blocked on one test. And I can tell you from my experience, because even now in Romania, not all cardiac centers have ROTEM machines or obstetric centers. So before having this test, I just had the communication with a surgeon, because this is essential in hemorrhagic, events. And also I took a tube. I put some blood from the patient, and I kept in my hand at the temperature of 37 degrees. And this is a kind of global coagulation test, and it should coagulate in 6 to 8 minutes. And after a while, if it's dissolved the clot, they have fibrinolysis. So clinical observation of the patient and the communication with the team is very important in your practice. And this is part of patient blood management also.
Thank you, Daniela. I am told by our timekeeper that we have 1 more minute. I'd like to encourage everybody to attend the 19th World Congress in Marrakesh from the 15th to the 19th of April next year. Thank you, Rosa, is flouting the WCA advertisement. Early bird deadline, the registration is now open, and the early bird deadline closes on the 21st of January. From the PBM side, please don't forget to encourage your societies to sign the Santa Cruz Declaration. And I'd like to thank our 3 speakers, Prof. Axel Hoffman. I always love hearing you speak, even though I've heard some of your lectures before. It's refreshing and fantastic. Daniela, thank you for bringing us down to earth with watching blood in a tube and does it clot. I grew up in anesthesia many years ago, and that was all we had. And we had a lot of trauma at Baragwanath Hospital, and that was all we had. So thank you for bringing us down to earth. Naima, I think you answered a lot of the questions on low middle income countries and sub-Saharan Africa, and especially obstetrics. There was one on ectopics. For anybody who feels cheated that their question wasn't answered, Daniela has undertaken to respond to it after we close today. So you will still get a response to your question. And to my fellow moderator, Vicente, I'm going to give you the very last word, which is unusual for me, who always likes to have the last word. So Vicente, you have the last word. Thank you.
Well, I'm very honored by that, Dr. Christina. So thank you very much for our presenters. Thank you very much for our audience. And thank you very much for WFSA and WHO for the phenomenal work at bringing patient blood management awareness to all of us. With that, I wish you all good morning, good evening, and good afternoon. Bye.
Bye. Bye. Thanks, everyone.
Yeah.
And thank you, Rosa, for keeping
Thank
us
you.
all
Thank you.
on time.